Hello, everybody. I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Today, we have an amazing topic. That topic is endoscopic spine and maybe the future and the past of endoscopic spine. We have a great group of panelists. I want to point out to everyone who's watching, if you have questions, feel free to put them in the chat. We will stop what we're doing almost immediately and ask you to undo your mic or not and ask your question to the panel, and we'll start going. I'm going to have the panel introduce themselves, and we'll take it from there. So, Saqib, Hasan, do you want to introduce yourself?
My name is Saqib Hasan. I'm a orthopedic spine surgeon at Golden State Orthopedics and Spine. It's a large independent private practice in the Bay Area. My career kind of started with endoscopic spine. I did a fellowship just I kind of knew very early on that this was kind of going to be the future of spine, so I decided to spend actually a year to learn it. And a fun fact about the panel and who's on it is that Sanjay and me actually went to the same high school. I just learned this like a couple of months ago. So, and it's not that far from you, Ira, in Brooklyn,
Oh, where'd you go?
Midwood.
Oh, Midwood. Oh, well, in the Flatbush area.
Exactly.
Yeah, very good. All right. New York geography.
Yeah,
Yep. Sanjay.
I didn't know we were doing fun facts. I have to think of one on my feet, or maybe I'll just leave that one alone. But I'm Sanjay Konakondla. I'm an endoscopic spine surgeon, obviously. I'm a founding partner of the Endoscopic Spine Institute of New York. It's the first endoscopic institute to fully dedicate all sort of treatments and surgeries to endoscopic. So, we're clearly motivated and encouraged with the technology, and we're putting all our eggs in one basket, betting on the future of spine surgery, shifting towards endoscopic spine, and we're doing it in New York City. So, but thanks for the opportunity to be here, and it's nice seeing a lot of familiar faces and names here. So, looking forward to the panel discussions. So,
Excellent. And by the way, great virtual background. No, just kidding. Just kidding. Welcome to New York City.
yeah,
Chris
there you
Young.
go.
Yeah, yeah. Chris Young.
Yeah, hey, so my name's Christopher Yeung. I'm here in Phoenix, Arizona. I'm an orthopedic spine surgeon in private practice. We have five spine surgeons, orthopedic spine surgeons with us. Uh, Took over my dad's practice. He just retired in 2019. I guess fun fact, gosh, I can't believe this. I'm saying this, but I've been doing endoscopic spine surgery for over 20 years. And, that kind of ages me. But it's nice to see that there's a big interest in the topic nowadays and that there's so many people picking it up and so many people here interested. And we got a great panel of surgeons here to talk about it. So look forward to the discussion.
Great. And Kern Singh.
All right. Before I talk about myself, I will say a shout out to Chris's father, who was a pioneer in this space, was probably a pariah for many years of his career in the endoscopic societies, but he kept preaching. And Chris has always been very balanced and well thought of, and kind of offers, an unbiased perspective in that sense. And I do appreciate his father's efforts over the years. With that being said, I'm going to say that everyone, what we always do in the talk is you provide your disclosures. I have no disclosures as relates to endoscopy. I believe that's in contradiction to the rest of my panel members, but I'll let them disclose that. I'm Kern Singh in Chicago. I am the chief of the section of spine surgery, the vice chair of the Department of Orthopedic Surgery, and I'm also in private practice. I've been doing minimally invasive surgery for about 19 years before there were CPT codes in outpatient surgery. And I picked up endoscopy about 10 to 12 years ago, uniportal endoscopy, and I have a slide on that as well. But I didn't really find it fit into my practice in a high volume setting, and it was really hard to learn. Pivoted to biportal over the last 5 years, mainly over the last 3 years. And I actually see one of my former fellows is on there, and then Mike Venetia, who is a spine surgeon, came and visited me. So if I say something that's BS, they can come and call me out. So I do think that I just may want to make it clear I have no disclosures in this space. I am not conflicted. I have no relationships with any industry player, much to the dismay of Arthrex, Joy Max, Wolf, whatever it is. And I think that the conversation has to be balanced by understanding what conflicts may lie in those relationships.
All right. I will leave it up to everybody else to um, respond or not to that. And because I won't put someone on the spot, but people could answer that or not. I want to start off.
I
Uh,
can answer that.
I'll go
yeah,
after
yeah,
that.
I
Go
think
ahead, Saqib.
I think that it's like I think of arthroscopy when I think of endoscopy, because when arthroscopy first came in the 1980s, people wanted to learn, right? And it's hard to be completely independent and teach other surgeons. So I do think, like, for me, my role in any kind of disclosure would be that I teach for all these companies because I love endoscopy. I think it should be changing the way spine surgery is practiced. And I do think that if a company is going to provide the resources to allow me to teach versus someone come to me or not, it's logistically a little bit more challenging sometimes. We're all busy, practitioners. So I think that most of the people here I met them through teaching. And I think that's it's something that's very humbling too, because you learn from your own shortcomings and you also learn from the people you teach around. So I think, when it comes to like industry bias and non-industry bias, I think endoscopy is a little bit different because I do think that when we think about industry and like having biases, we think about more metals because metals are very expensive. And I think when we talk about this a little bit later, I don't think endoscopy is a money-making game. I think it's a paradigm shift that's happening in spine surgery, and people either know how to do it or they don't. And if you know how to do it, you're probably going to benefit a little bit because you're going to teach people.
So I take the conclusion, Saqib, that you have a conflict of interest. You should join me and teach for free.
I would. I do actually. I've taught in many courses.
Okay, so that's great. I just think that understood your relationship. I'm just pointing out for the industry. People invited me on the panel because of my lack of conflict. I just want to make it clear people have conflicts. We all have conflicts, not a metal or not, but conflicts are conflicts. And I just want to make it clear that I have no conflicts in the space.
Yeah, it's always interesting when Kern's going last with the introductions. You always have to be wondering what he's going to say there. So, welcome all the provocative statements. But Kern, what are you doing with your trays? Are you selling those trays or giving those away for free?
I sell them at a nominal cost increase. Actually, it's less than the tray itself will cost less than one of your procedures with Arthrex.
Okay, so can you describe what you're doing with these trays or?
Well, let's start with your conflict of interest first, Sanjay, and then disclose that, and then we can get into the conversation.
Yeah, I didn't get that part of the agenda where this is part of it.
I
So
know, but it would be really simple to start with it. That's what people do actually when you go on the podium somewhere. You start with your disclosures.
yeah, absolutely. So you brought it up, so I think it's only right that you start. So can you describe your trays?
Actually, no trays have been sold.
Okay, so you do have a conflict in trying to sell those.
No, I don't actually sell them to. I have surgeons who visit me, and now you can ask them. I have Dr. Venezia on the line. Can
I
you,
just don't know, so
Doc?
I'm just asking
No,
you
no,
to
I
describe
know, but
it.
I think that's an Arthrex tattoo on your shirt there. So you just disclose
No, it's
Arthrex.
my own institute, and
I know,
yeah,
I
yeah,
know,
yeah.
I got it, Sanjay, I got it. I'm just telling you, it's simple. It's simple. Just provide your disclosure, or I can go on ProPublica and find it. But either way, it's Arthrex on there, so we can move on from that.
Yeah, so now everyone knows my disclosure, so you can describe your trays, or you just don't you're
Maybe,
deciding not to do that.
maybe we should just keep going talking
maybe
about.
we should keep going. Okay.
Yeah, keep
Yeah.
Here, I
going.
want to disclose some stuff. So obviously, my dad developed the first working channel commercially available endoscopic system with Richard Wolf. So he got some royalties for that. I taught for them for a number of years. I got hourly consulting rates for that. I've taught for Elman and subsequently Eloquence. Got some, hourly rates from that. I also teach for Arthrex now. I get hourly for that. I don't have any, I don't know, royalties or anything on anything that they sell right now, and endoscopic at all. But I do teach for them right now, and so that's my disclosures.
Chris, you have always
I
disclosed. I've
think
never had a
teaching is an
concern
awesome
with you,
disclosure, by the way.
Chris.
I think teaching is an awesome disclosure. I'm so proud that I'm a teacher, and I'll disclose that all day. I mean, I don't make any money aside from me teaching. I would love to teach for free, but I got a busy practice. I can't be teaching for free.
Yeah. Also, I guess I have two other disclosures.
I guess
I
that's
did.
interesting. I mean, I have a busy practice too, Saqib. I think most people would attest to that, but somehow I'm just saying there is a conflict, and Sanjay disclosed a conflict of mine, which is a tray that has not been sold. The cost of the tray will be priced it'll be a non-disposable tray, will be the price at the cost of around one Arthrex disposable case.
Yeah, the comparative disclosure is interesting. I don't know if it's right to just,
How can I
present
disclose
yourself
something I
as
haven't had a dollar on?
I'm sorry.
How do I disclose
I
something if I
mean,
haven't had a dollar?
if you'd let me finish, I was just going to say that I don't think it's right to just, present yourself as holier than thou when there's actually a disclosure, whether nominal cost or not, you have something to say. So, it went from absolutely nothing to something that you're selling for a little bit of money. So I think that to be completely transparent here, we need to have that
Okay,
conversation. Because
my disclosure is currently I have a nonprofit spine training education program. I guess unlike Saqib, I'm not that busy, but I teach for free. Those surgeons come and visit me for free, of which there are, I think, 5 surgeons on there that have visited me for free. I have never sold them a tray. They have asked for the tray that I'm selling at nominal cost, above the price of one disposable case that we can get into. I have not sold any trays, so my current disclosure would be $0.
I think Dr. Plancher wants to say something here. So
All right. Wow. Okay. Kevin.
Good evening, gentlemen. I want to say that first of all, I'm elated and excited to learn why endoscopic spine surgery has any value in our world, and so I would like to hear about it. I want to say that doctors are underpaid today, and you're all silly college graduates. New York Times editorial says we should be paid 5 times what we get. By all means, treat people that don't have money free. Get off this bandwagon. I'm delighted you're conflicted. I hope every one of you on this show is conflicted and makes more money because we're being stupid. Look at Air Canada. They're getting paid. They strike. We should strike. Let's move on, Dr. Kirschenbaum. And I want to know why, if my back hurts, I should bother with this newfangled thing. I don't want it experimented on me, and I don't want the level below me to be affected because I don't believe in spine surgery because it never works. So help me to know the science, please, Dr. Kirschenbaum, with all these wonderful, brilliant people.
All right, Kevin. So
Yeah, Kevin, I'm with you. I'm with you. Let's hear some education.
let's hear some education. My conflict is that I know Kevin Plancher. So with that, we're going to go right to our first big question. All right. Which patient, the question really is which patient populations really benefit most from endoscopic spine surgery? Chris, could you start us off?
Oh gosh, I think the busy professional, the athlete, anyone who wants to minimize their downtime, because we always talk about cost to uh, whatever insurance company, to the patient, hospital, surgeon, what we're getting reimbursed, but what's the real cost in terms of lost time and productivity to the patients, right? And so it's something, if we can take care of the problem and we can do it in a less invasive way where they can get back to work, get back to life, get back to their activities, then they're more productive. So I think that provides a tremendous value to the patient. So, busy professionals, someone who needs to get back to athletics, especially professional athlete, those are sort of like the easy top, populations to say.
Okay. Sanjay, your view on which populations benefit both, or is it possibly every population benefit both?
if I could cheat a little bit and take it by pathology, I would say everyone walking around with a thoracic disc herniation or any ventral pathology in the thoracic spine. Because, I mean, people on here probably would have guessed I would have said that, but the delta, surgical invasiveness compared to, against the symptomatic relief is just the biggest in this patient population because obviously we're able to get to these areas without shark bite incision, rib resection, or splitting the ribs, lung retraction, significant bony resection or collateral damage that may or may not require instrumentation, and then chest tube placement, potential ICU stay, prolonged hospital stay or length of stay. And then you do the uniportal endoscopic approach where you're transforaminal or transpedicular, depending on the level and where the pathology is. It's an 8 mm incision. It turns into an outpatient procedure, and the patient has minimal to no pain. And we don't routinely prescribe postoperative opioids for that. So it's just like this huge difference there. And of course, we talk about what the best cases are and what the first cases are, and those are very two different things. So, everyone wants to, get their hands on the scope to try to do these high yield cases, but sometimes they're not the easiest. So, far lateral discs and thoracic discs are perfect for it, but those aren't the cases you start at. So I would, argue that people need to pick this up and do the chip shot cases, and it's not just a fancy way to do a lumbar disc, but it's rather a gateway to allow your practice to evolve into treating these patients in a much better way. And we've obviously published on that too. So,
Saqib, what are your thoughts about that? And also possibly add, is there a limit to the expansion of the indications?
So we published this paper back in 2019 called The Benefit Zone of Endoscopic Spine Surgery. And I reference it a lot because at the time I really wanted to understand that question. And we literally we delved through all the best available research. We're talking the best randomized control studies. Everybody knows the sport trials have such excellent data. And surprisingly, endoscopic spine surgery, uniportal techniques have some of the best randomized controlled trials in spine surgery. I mean, they're up there with the sport trials. And bottom line, we went through all this data, and we saw that the benefit zone, it's not going to be for the discectomy, really. There's the improvement for discectomy is probably marginal, and yeah, it might be marginal to the surgeon, probably not marginal to the patient, which is a different discussion. But really, the benefits of endoscopic spine surgery shine when the alternative options become increasingly invasive and complex. Like Sanjay just give an example right now with thoracic disc herniations. He gave the alternative options, and those are all scary, right? And then you talk about, some people who come in with a, foraminal disc. I'm sure all the surgeons here would be able to decompress that, but a lot of people I know sometimes will just say, "Oh, that's a TLIF case," and then the alternative option from a far lateral discectomy versus a TLIF is very different, right? So I think for me, it's going to be pretty much any decompression that you can essentially attack the main pathology without exposing the patient to the undue risk of a larger, more complex surgery. And so far as endoscopic goes for me, I used to do some endoscopic fusions. I'm kind of shying away from that. I'm kind of going back to more traditional ALIFs and laterals, just because I don't think endoscopic can really, the technology right now has the cages, in my opinion, to really, at least with a uniportal approach, to really recreate an ALIF or a lateral, things like that. So for me, I like to pick and choose, but for me, most decompressions, I will like to go endoscopic because of the reasons I discussed.
Kern, I'd like you to expand a little bit on this and also talk a little bit how people get into endoscopic surgery. And I also want you to talk about what are some of the limitations of pathologies that you would draw the line at.
So, yeah, so great question. So I'm going to actually agree with Sanjay on some of the points and then maybe refine a little bit of the answers. But, you know, I just want to make it clear that for those who are online who may not know, endoscopy is not just one camera uniportal. It can be biportal or two cameras, more like a traditional knee scope or shoulder scope. And I think that's part of the marketing push out there that it's uniportal endoscopy or it's a bust. I do both. I do think what Sanjay said, thoracic ventral pathology in my hands, central pathology is very well addressed with uniportal endoscopy. And that's where I believe it really shines. And I'm the first to admit that. And anything that's calcified central, but anything else, I believe 95% is addressed cost effectively with biportal endoscopy where there is no additive cost. So going back to, I also agree with what Sanjay said. Let's be very clear that I don't think there's that much of a benefit in lumbar pathology with endoscopy, tubular discectomy, or even open discectomy. And to Saqib's point, the spinal endoscopy study, I think that he was citing, was the study from the Netherlands in 2021 or 22. And that actually was a non-inferiority trial. That just showed no difference between a open discectomy and a full endoscopic procedure. So I would just temper that enthusiasm. And I don't believe that that's an accurate statement. Going back to it, I think what Sanjay said is accurate. It's complex pathology where endoscopy wins, whether that's biportal or uniportal. So cervical pathology, thoracic pathology, central thoracic pathology, where I do believe uniportal shines, I will agree 100%. And I think that lumbar pathology is just the easiest to get into. I think it's the easiest to mix into. I think the advantage of uniportal endoscopy is that for cervical and thoracic pathology, fluid pressure is not an issue. It is more benign. Biportal endoscopy has more of a challenge with cervical and thoracic pathology. We just put out a survey over 100, ended up being 140 surgeons across the world. Was an interesting fact and if we cut them off at having done at least 100 endoscopic cases, biportal or uniportal, only 20% were doing any cervical or thoracic pathology. So that does not mean cervical foraminotomy. I'm talking full bilateral decompression cervical. And that's kudos to Sanjay in doing thoracic pathology, which very few people do. But I don't think there's that much of a delta in the standard lumbar pathology between a tube and an endoscopic case. And I do it only endoscopically at this point.
Interesting. We have a question from Mike Venezia. I hope I pronounced it right. Mike, you want to give your question or?
Sure. I guess since I've already been called out by Kern, my journey up to hang out with him was due to my early experiences with both biportal with a disposable system that was quite expensive, as well as uniportal, which I did one today with Arthrex, and the biggest hurdle is moving these cases to the ASC, as well as the type of pathology that you can treat. It seems to be more limited with uniportal, at least early on. I'm admittedly 20 to 25 cases into my endoscopic career. So I guess the biggest question for the panel is how do you overcome, especially Sanjay? I know we were hung out together at Arthrex and you're fantastic, but starting your own institute, how do we overcome, these costs? How do you guys overcome these costs when we're billing the same 63030 code in our ASCs?
Well, I'm making a lot of money off you, Mike. Apparently, I sold you 15 trays already and
I
Dr.
agreed to
Plancher
eight. I agreed to eight.
and Dr. Plancher says you're making more. So I guess, let me know when you're going to buy a tray and then we'll talk.
Sanjay, you want to ask that question about the cost?
Yeah.
Yes,
So
because you've really put your eggs in quite a big basket here.
really, really have. Yeah. And, I think that there's a lot of systems. So everyone just thinks like you have to buy this full tower, obviously. And I will submit that biportal is cheaper than uniportal, right? Because of all the obvious things. But I think that you don't always have to buy a full tower, right? Cameras, irrigation systems, drills, all these things for the most part can be white labeled, right? They're all optical scopes with rod lenses. They're all rigid scopes with working channels. And they all have the same optics, right? You have the quality of the video up to HD or 4K. I think that my answer to that is always more philosophical, right? We're trying to solve a quality of life surgery, and a quality of life problem with a quality of life surgery. So what does that mean? Does that mean we look for the faster surgery? Does that mean we look for the cheaper surgery? Or does that mean we look for the surgery with the least amount of collateral damage? And I think obviously it's the latter. So I think that early on when we're adopting new techniques and new technology, I will be okay with things being more expensive because as people adopt and use these techniques, the technology will follow. And, I think that we're still in the beginning, right? Endoscopic spine surgery is not new, but we're still super early hockey stick as far as the technology because we're still connecting fiber optic cables to rigid rod lens ports or rod lens rigid cameras to get the surgery done. What about chip on the tip to make a scope flexible? What about smaller cameras? What about digital optics instead of fiber optics and rod lens optics? So I think there's so many more things that we're probably going to say is more expensive as we develop more and more with these techniques. So I think it's a now problem. I just think that eventually we'll get over it. But if you come back to what we're all trying to do, we're all trying to work for the patient, right? And I think that if we talk about speed of surgery and the cost of these things, these are all real things. But I think that we have to stick to the basics of what we're trying to do. We're trying to make surgery smaller. For people who are in pain, the surgery has to hurt less, and all the complications and risks have to go down. So I think if we can accomplish that, we can figure out the rest, or we should figure out the rest. So I'm not saying it's not a problem. I'm just saying that hopefully, with more efforts united, we can slowly get over that.
Well, let me challenge you on that, Sanjay. So I agree the thoracic pathology you can demonstrate. I mean, there's no question, even
Yeah,
cervical pathology.
yeah,
But in lumbar pathology, where the data is neutral at best, and you
hmm
take a fixed margin reimbursing procedure in a
yeah,
typical ASC, which is where most people are doing these because it should not be done in the hospital at this point. It's not cost. It's not does not make any cost. You take $10,000 for a reimbursement, Blue Cross Blue Shield in the state of Illinois, in Indiana, whatever. You have 50% due to fixed overhead. You have labor costs, you have material goods, you have whatever. You have a nominal margin of $3,000 per case. How do we justify $2,500 to $3,000 going out the door for quote unquote a less surgery? You said that, but then what
hmm
the problem that I have when endoscopy is pitched is that full, which I believe is a terminology created by Mark by industry, full endoscopy or uniportal endoscopy is so much better and less traumatic than biportal. You argued about betterment of technology. I would argue the opposite. I would say Mike Venezia, some other people have come, Tristan Free, who's my fellows online. You can do biportal endoscopy using a standard 0 degree scope and the standard instruments, and it costs $125.
So
yeah,
can I jump in
Yeah.
here? I,
Oh
I
yeah,
have
Saqib.
I have a couple comments. So, first, I don't, my disclosure, I'm an owner in two ASCs, and we have endoscopic equipment there, and I do a lot of my endoscopic cases there. I do some in the hospital. I know how much these things cost, and they're not $2,500. On average, an RF probe costs anywhere from $300 to $400, and on average, if you're going to use a drill, it's going to cost anywhere from 600 to 800, depending on the company you go for. A Medtronic drill, if you're going to count in my surgery center, if you use a Clearview drill, it's $600. If you use a regular MH standard drill, it's about $300. But we're talking about maybe $500 to $800 in difference between per case. That's number one.
No, that's not accurate,
Let me just finish.
Saqib.
Let me
Come
finish
on.
my point.
That's
Well,
not
that might not be for
accurate.
you, but it is for me, and that's my experience, so that means something, right? But anyway, my point is, I wanted to shout out Siva. He's on this because he just published a study that I really love, and Siva's on this chat, and he actually looked at this at Jefferson. And Siva, are you online? Can you unmute
Yeah,
yourself?
yeah, I'm here.
Because I think your explanation was just amazing, and the way I think we can all learn from you on this regard because you actually studied this.
Sure. Yeah, yeah. Yeah, happy to speak on it briefly. We use time-driven activity-based costing to look at um, uh, uniportal transforaminal endoscopic discectomies versus open or tubular discectomies at Thomas Jefferson University Hospital. And in our study, we didn't find a significant difference in true intraoperative cost. The caveat there, of course, is that it was just two surgeons doing endoscopy, and it was a larger set of the spine surgeons at Thomas Jefferson who were doing the open or tubular discectomies. And it was only uniportal transforaminal, so for far lateral pathology. And I do think it probably warrants a bigger study, but we were interested in the results because it sort of went against the sort of traditional assumption that there was a huge difference in per case costs.
So I'm very familiar with the study, and my fellow was at Jeff, and I know Alex very well. And there's like you said, rightfully so. There's a lot of caveats to that study. Two, I'm going to go back to what Saqib said. Biportal endoscopy has no added cost except for the RF because you're comparing it to a tubular approach or a microscopic approach. The delta, as you mentioned, is not just the per case costing. It is also the sold tower and the capital equipment. We have a bunch of surgeons who have attested. That's the initial layer for prevention of adoption. I'm not arguing that uniportal could not be done elsewhere or in more cases. But the average surgeon on this call, and even myself included, is dealing with 2, 3 level stenosis, multi-level disease. And it's not just the simple disc herniation or the foraminotomy. And I think that it's just a costly, expensive venture.
So I think Kern puts up a great point because a lot of people starting endoscopy in terms of the startup costs, you got to differentiate between disposable per case costs and capital costs. So a lot of surgery centers, you're already doing spine surgery. You have a microscope that costs, whatever, $250,000. You have the Metrex tube set and instruments, which cost $40,000 to $60,000. You already have that, so you're not having to outlay that right away. But just and for biportal, you already have a tower, you already have a camera, and then you just plug in the sports scope there. So when you're starting like uniportal endoscopy, you still have the tower, you still have the scope, but you got to buy you have the camera and the tower, but you got to buy the scope. Okay. So that's about 15,000 for Arthrex. That's like their list price. And then you have to buy the instrument set, which is the tubes and the specialized pituitaries and stuff. And that can be about $60,000 to $80,000. So it's significant. But once you have all that stuff, it's not disposable. You reuse it, right? And so for me, we have all that stuff at our ASC. The only cost I have is the RF probe and the tubing. Tubing's only like $30 for like the pump or gravity. It's about the same. And the RF probe, depending on what company you get, anywhere from like 400 to 1,000. So that's more expensive than the RF probes that are used in biportal, which are probably about $150 to $300. So there is a little bit increased cost, but I don't ever use like Flow Seal or anything, which is maybe like $300. So you're saving a little bit there compared to regular open or micro discectomy, not necessarily biportal. But I think you just got to differentiate between the capital costs and the per case costs because it takes an initial capital contribution.
Let me make it very, very clear to everybody. So I agree with you. I'm not damning uniportal endoscopy. I do uniportal endoscopy for thoracic pathology, ventral. What I'm merely saying is there's a reason why limitation and adoption of uniportal endoscopy is not occurring at a faster rate in this country. So
Absolutely.
I'm not touting my own horn, but I've got 100 surgeons on the wait list. I have 4 surgeons every week coming to visit. And the reason is twofold. It's really easy to explain. Number one, a surgeon goes and visits Sanjay, Saqib, Arthrex, whatever it is, Joymax, doesn't really matter. They go to the center, they do a transforaminal approach. It's not familiar anatomy. It's just really not. It's not intuitive anatomy. It can be. Then they kind of learn it over a 12-hour period. They hang out, go to the clubs at night, and you got to remember the procedure that you did the day before. And then they go back to their hospital and the surgery center to say, you know what? It's going to be a $50,000 outlay. It's going to be XYZ. It gets tied up for 6 months to a year in buying it. By the time they buy it, if the hospital even agrees to it, because they don't want to invest in it because you haven't done a case, and the hospital doesn't see, or the ASC doesn't see a incremental delta on their return on the investment, they say, okay, it's 6 months to a year, we're going to get it in. By the time they get that in their place, they haven't learned the technique, and the anatomy is not really forgiving, and the pathology is not really addressing multi-level stenosis and disease and typical, like what we typically see. That's in contradiction to biportal. Biportal, you're like, okay, so I'm going to sell my tray for $1 million, like Sanjay said. I'm going to make $1 million a tray on my profit. They take it to them. All they want is a tray. They get it right away. They come and see the anatomy. Oh my God, it's very, very similar anatomy. It's what I see. It's the pathology I see, and I can start up tomorrow. And so my point is not, I'm not arguing against uniportal. The two things I'm arguing against, I think uniportal is here to stay. I think there's value in uniportal. I'm arguing on a artificial makeup of price by industry. It's bogus. In most countries, it does not happen. The price is the same. It's an artificial barrier to adoption. And I think, two, I think the promotion of uniportal above biportal is artificial at best because we just heard Saqib say, well, I don't do fusion. I just go to the ALIF or lateral. So we're not really talking about smaller surgery. And that was in the fusion context. So we really can't say that uniportal is less destructive than biportal. If it is, maybe it's marginally so, but no less than tubular or microscopic, where the data shows it's very equivalent.
Ira?
Yeah, I'm gonna switch. Kevin, I just
Yeah.
move on to some clinical stuff, but go ahead,
Right.
Kevin.
And can we, in the 21 minutes so I can leave here, know before we leave the three operations? If I walk into a spine surgeon, I should demand an endoscopic spine procedure as opposed to an open one in 2025.
Right. That's a great question. So let's flip to that question right now. What three operations, if I walked into any one of your offices, Saqib, we'll start with you, you would say, no question, endoscopic.
Definitely a foraminal disc. That's just like easy. I mean, a foraminal disc herniation, a foraminal disc herniation. My partners almost always send me their foraminal disc herniations because they don't feel comfortable. They would feel comfortable preserving the facet. So that's one I'd say you have to do endoscopic. Same vein, I'd say a thoracic. Obviously, those are more rare. And then for me, I think one of my favorite cases is a posterior cervical form anatomy discectomy. I just did one last week. Just the visualization you can get in there, and you can avoid an ACDF or a disc replacement. You don't burn a bridge to those procedures later. In fact, a lot of my patients come to me specifically to seek that procedure because I mean the incision is literally like 7 millimeters. They go home. I can get the disc very safely. I mean, it's one of my favorite procedures.
Chris, what do you think? What you agree with that?
Yeah,
You
so I'll
add
say,
some procedures?
yeah, three examples. So like extraforaminal or foraminal L5S1 disc herniation. That's a TLIF in most people's hands. So if you can get that without and save them from a fusion, that's a big benefit to the patient. Second, L2-3 extruded cephalad migrated paracentral herniation, sagittally lined facets. Most people will either fuse that because they can't decompress it without destabilizing them, or they'll do a two-level laminotomy discectomy to get it all because the interlaminar window is more caudal. So if you can get that transforaminally, you're saving them a much bigger procedure. And three, I think this is not talked about a lot, maybe because people don't want these patients, but people coming in with discitis and kind of ventral epidural abscess. Do a uniportal discectomy, debridement, just like any other place where we're debriding an abscess or anything. You can go in there, not create a big amount of dead space, get a really good tissue sample, not just a fine needle aspirate, and then you can target the antibiotics. Then you've also decompressed the amount of bacteria right there. I think that's a big win compared to open procedures. And of course, the thoracic.
Thoracic. Yep. Kern, you agree with these as ones? Any others to add?
Well, I'm going to flip the question a little bit, and I'm going to say, why would you go, Kevin? Kevin, why would you? Why? It's not a patient like a specific to endoscopy. I would argue it's the same as in your world. Why would you get an open ACL repair done? You just wouldn't. So I would tell you the faculty on here can address any pathology and all pathology. So in their hands, I would tell you go to someone that's an expert in endoscopy, and that's what you would want to do because they can address any and all pathology. As far as pathology, that's the biggest delta. I would say what Chris said, which is the infection, what Sanjay does, which is the thoracic case, and cervical pathology that is truly like stenosis that you prevent them from an open laminoplasty, a posterior cervical fusion. These are huge wins for patients, but I would say seek out someone that does high volume endoscopy in general for complex pathology, and your delta and your win is great.
I want to ask Sanjay my favorite innovation question. which is if this innovation came out first before we did any open spine surgery, would this be the gold standard for if this came out first? Would we? It's like if a digital camera came out first, you'd never think of going to film, right? You know, just, so if this came out first, when you first started training, and then someone came up to you and says, "Hey, I think we want to open you front to back," versus endoscopy, where would we be right now? As far as the learning curve and what kind of operation would go away?
Yeah. Well, there's so many ways to answer that question. It's a really good one. I'll start with the story I always give. If you walk into my house and all the lights are off, okay, and you open the door, door's unlocked, you're tripping over my snowboard, you're slipping over a piece of paper that I left on the floor, you're tripping over the coffee table before you reach the light switch, right? If I walk into my house and the lights are off, I'm walking around the snowboard, I'm stepping over that piece of paper, and I'm walking around the table and I get the light switch. You may not even reach the light switch, right? That's only because I know how my house looks with the lights on. Right. So that's to say, I don't think we'd be here right now if no one here has done open surgery. I did fellowship with Ziego Koslin, and we opened the spine up in all 360 views to take out these en bloc tumors in the mobile cervical spine and the sacral spine, and we put it all back together. I would say that I'm a better endoscopic surgeon because of that, because I'm looking through this hole and I know everything that's around me, so I know which direction to go, whether it's ventral, dorsal, cranial, caudal, or whatever. And I think that helps me with targeting, but that helps me with damage control, and that helps me with being super purposeful in my movement. So that's what I would say. I think that it's still important to know how anatomy looks, and if the technology improves such that the trainees going forward don't have the exposure to open surgery, I think there's always going to be cadaver labs to learn from. So
What are some of the unique risks related to endoscopic surgery in, let's say, the first 50 cases? Because people want to get there. And, it's like the anterior approach in hips. There's a lot of femur fractures, there's a lot of things. What are some of the inherent early risks? Now, Kern, you see a lot of people come through your place. Okay. What do you caution them about early in their learning curve?
Yeah, so one of the lectures I give was on my MIS learning curve, which is kind of the ethics of the learning curve. And I talk about the good, bad, the ugly. That's 19 years ago being self-taught. I was a dural missile and misplaced screws and non-unions. What I see in endoscopic surgery is what's the biggest risk? The biggest risk is inadequate decompression or inability to complete the procedure. That's really the number one risk. And you see that all the time. So that's not necessarily a knock, but that's just a reality. So I always tell surgeons to have a backup plan, which is why I think that the adoption rate for biportal is a little bit higher because you can convert to a tube or a mini open that way. You're not so far out. But you should have it. And I think it's okay to go uniportal and then consent them for a decompression if you can't accomplish it or whatever it may be. But inadequate decompression. And the second one is probably a durotomy of some sort. The dural tear is probably the most common. Now you can make the argument that it's probably a small tear, it's inconsequential. But those are what the durotomy or the dural tear ultimately leads to is a furthering of the inadequate decompression or inability to complete the procedure because the vast majority of people, it's lumbar-based pathology. And I go through, it's never a number. It's an ability to repeat the step in a reproducible fashion. And that's the biggest challenge. And so, the challenge with anything with endoscopy, whether it's biportal or uniportal, is that you ask any of these surgeons who are very talented, Saqib, Sanjay, Chris, it's reproducible in their hands. They do the same thing. They do the same thing over and over again. They don't stray at each step. They get each step done, accomplished, and then move on. And part of that's just hard to incorporate into some practices. And I think that's a big hurdle.
There were two questions, one from Siva and one from Aaron Smith. And since they're both similar, I'll ask the question for them. What about recurrent lumbar disc herniations? Well, recurrent herniations, is that an issue? Is that a problem? Saqib, you want to take that or?
Yeah, I mean, for if you're saying it's a recurrent disc herniation and the index procedure was an open or tubular surgery, or just any procedure that uses an interlaminar approach, if the pathology is amenable to it, a transforaminal approach allows you to avoid the scar tissue, and it makes that surgery like a native surgery. Obviously, there may still may be some scarring in the lateral recess, but if the herniation is more ventral from a transforaminal approach, and a couple of things about the transforaminal approach. We talk about, really talk about biportal and uniportal. I actually do some biportal too. And I do them for more complex cases. And if it's like a lot of scar tissue, a lot of vision, or a lot of levels, I find that in my hands, I'll go biportal for some of those cases. But when it comes to one level, two level disease, I usually will go uniportal. But one thing about the uniportal, I think the workhorse, in my opinion, that's so unique from, I guess, most other procedures in spine surgery is that, White and Punjabi did this study, one of the earliest biomechanical studies. The White Punjabi are like the biomechanic gods of spine surgery. And that study showed that it had the most increase in foraminal area and the least amount of destabilizing effect on the spine. And I think that it goes to show that I think that for me is one of the main reasons why I use uniportal surgery. And again, I guess I'm not saying uniportal or biportal or better. I think they're both all part of the same spectrum.
Yep. So some other comments about that. Otherwise, we'll go on. We have another question. I think Siva, I've learned that your name. You talked about lumbar endoscopic foraminoplasties. You want to ask that question?
Yeah, thanks. Just on the topic of the sort of utility of endoscopy in the lumbar spine, curious what the panelists think about. A patient that has bony foraminal stenosis, unilateral lumbar radiculopathy that in most surgeons' hands might end up with some sort of fusion, where in select cases you can do a transforaminal foraminoplasty, open up that exiting nerve root and avoid a fusion. Those kind of procedures to me seem like a huge opportunity for a delta and an advantage that sometimes gets missed when we talk about, hey, I can do a discectomy through a tube or open or through an endoscope. But those kind of situations I think could be powerful. Curious if the panelists agree.
So
Uh,
I agree. I do those typically paramedian or biportal. I do those in DGN scoliosis. I don't think you have to be transforaminal. You can go extraforaminal into the foramen and do that routinely. I think some of the surgeons on here have seen me do that. Far lateral disc herniation foraminal. You can go into the canal biportal as well. The one thing that we haven't mentioned, and I'll just say this, and my biggest concern with endoscopy in general, because the panelists here are looking to minimize surgery, and I do believe that's their intent. But the biggest concern I have is with industry, which is this is going to be falling into the hands of pain doctors. It's really clear that there's certain movement to that's a larger market. It can gain traction very quickly. And I have a significant concern for it. And, the thing is, we have done nothing to kind of limit that. That's my concern with this kind of growing. And I don't think this is just a random fear. I'm seeing it with growing adoption, and industry is looking the other way. And I don't think they're going to align with us to limit this. So I'd be curious as to what the panel thinks about that.
all right, let's do two things at once. If everyone agrees with Kern's view of the endoscopic foraminoplasties, we can talk about the encroachment of another specialty, pain management doctors into this space. You see that as a future? Anyone? Sanjay, you?
Before we
Yes.
go ahead,
Oh, Saqib.
I had this video that I was going to show anyway. I figured since Siva asked about it, I mean, it's a pretty good. I'm just going to show it real quick if you guys can let me share
Yeah, you
here.
can share.
This is the video. If I can play this. So Siva talked about this. This is like the perfect patient. You can see there's complete foraminal collapse here, and they specifically came to me saying, "I don't want to fusion. All my partners wanted to fuse them," and you can see, you can again look at the CAT scan. Everyone can see the screen, correct?
Yes.
And we kind of go forward a little bit. You can see there's that vacuum gas phenomenon. It's just the frame is totally compressed. And then this is just like the endoscopic view. You can see that's the exiting nerve root right here. And you can do this beautiful decompression. And I'm not saying you can't do it, you can only do it uniportal, but I'm saying this is kind of the perfect patient, I think, that people don't think about, because when you talk about costs in spine surgery, we shouldn't be comparing uniportal and biportal. We should be comparing endoscopy versus regular spine surgery. And in that case, we're definitely the winners. Because I think in anyone else's hands, this is going to be a fusion. And you can see
I mean, this is similar. I mean, Sanjay's partner Albert Telfian posted the same thing. I commented on social media. I thought it was a beautiful foraminoplasty, and I do believe that. I do believe your point about endoscopy versus non-endoscopy, but I do think there's a bigger concern that will this technology and technique and procedure will slip out of our hands, and there'll be scope creep by other professions.
I agree with you 100%. And we talk about it all the time. And I'm sure the rest of the panelists will agree as well. I don't know how you can stop that. I wish I did know.
Yeah, I mean,
I agree as well.
It's tough because obviously they're trying to expand their, I guess, toolbox and everything. Pain management guys are doing SI joint fusions. Some are doing percutaneous screws, so, and they're kind of marketing themselves as interventional surgeons or, something of the like. So it's tough. And, I'm not going to be here and say, okay, if you're a pain guy, you have no dexterity, you cannot you're not able to do this effectively, because there's some, they're really talented, right? But they're a super minority. And so that's the problem. Their indications are completely different. They have a mindset of, okay, let's try this. If that doesn't work, no big deal. We can try this. If that doesn't work, we can try this. Whereas we know we want to be one and done with a spine surgeon. We don't want to have to go back. And then you're dealing with scar tissue and different and altered anatomy. It's a different game. So, I mean, it's a different mindset from us as surgeons and pain management guys. So I think
Yeah, I
it
don't
is a
have
little
an answer.
dangerous.
I don't have an answer. It's just more of a concern that I do believe there will come a time when industry will looks the other way. And I do believe what Sanjay said is very accurate, that being a good open surgeon helps you understand pathology. It makes it easier. It made it easier for
100%.
me made it easier for me to transition to tubular, made it even easier for me to transition to endoscopic. You just know what you're looking at. And I think
Yep.
the ones that come out, whether that be, pain management trained or people who come, I just want to do endoscopy, I just want to do whatever, and they don't see the open anatomy. They really struggle in the transition.
100%. 100% agree with that. I will have to say that, most of the legacy companies, they'll train all comers, right? The one thing about Arthrex, they've told us and a commitment that they are not planning to train pain management doctors. They're a
So I
surgeon-based
only
company.
mention it to you guys, and I mentioned because you guys do teach on this, that I would ask you to understand and to silently or openly protest about training non-specific spine surgeons. I went to the inaugural UBE society in Europe. This was this past year, and there was one that was a pain management. I said something like, "I'm not coming back if we're training pain management from the other, like, I may not be able to stop the tsunami, but I just don't want to be complicit and part of it."
I think that you're 100% right. When I talk to any company that I teach for, that's pretty much understood. I know that Joy Max and Arthrex don't teach pain management doctors. I don't know about all the other companies. But one suggestion that I had to a lot of my colleagues about this is, I think that really the answer to that question is going to be, how do we educate patients? Because if patients knew what we knew about what can go wrong and who's handling it, they would never go to a pain management doctor. And I think it's our duty, and I don't know, maybe through, we talk about
For surgery.
Oh yeah, for surgery. Yes, let's be specific. For surgery, not pain, but we're talking about endoscopic spine surgery. And if they went to a pain management for endoscopic spine surgery and there was more greater awareness that you probably shouldn't do this, is not the smart thing to do, and maybe that's going to be efforts through, like, Kern's UBE, or maybe it's going to be through ISERP. Sanjay is the president of that, and that's probably part of the agenda things we talked about, is how can we bring greater awareness to this issue? Because you're right, we can say, people can argue from a perspective, yeah, it's creep, and that it's a monetary thing, but I think it's a patient safety issue.
I always felt that if you can't get out of problem and do an open procedure, you probably shouldn't do the index procedure. And that's one of my arguments a lot with people. It's a little bit like robotics in arthroplasty. Eventually, if the robot doesn't solve something or is malfunctioning, you got to know how to do a conventional approach. And I suspect that maybe the malpractice world, unfortunately, will realize if they get into trouble endoscopically and start doing some damage, there may be an outcry. Hopefully, there would be an outcry, and there's creeping all of orthopedics, right now. What I'd like to do, we're sort of at the end of the fastest hour in orthopedic history. All of you could have probably done 3 endoscopic lumbar foraminotomies in this time period, and so I appreciate you spending the time with us tonight. I would like you, please, we'll go around the room and if you guys could give us 1 or 2 take-home messages about endoscopic spine surgery that you want us to walk away with. And the first person I see on screen is Chris. So, Chris, you don't have as much time to think about the 2 things. I apologize.
Got it. Well, I think they're compared to decades ago, there's a lot of training options now. And so if you're interested, take advantage of some of those training options. I think you get better training with the industry sponsored ones versus, say, like the society courses, because at society courses, you're like 6 or 7 people to cadaver. You don't hardly get any time. So take advantage of one of these industry courses or one of Kern's, free courses and, get some hands-on experience. And there's a lot more companies now. So it's exciting time because there's a lot of opportunities for everyone to learn, biportal or uniportal.
Excellent. Sanjay, a few take-home comments.
2 things split in 2 headlines. One is it'll change the surgeon's life, your life, and it'll change your patient's life. So in the beginning, it'll be hard because you'll be frustrated by super easy cases or what used to be super easy cases for you. And now you're applying this new technology, like Kern said, transforaminal, same anatomy, different view. It's going to get really frustrating. You're going to feel like a failure, but you're trying something smaller for your patient before walking up to big open conventional or MIS surgeries. Your patients will get younger, or your spectrum of your demographics will widen or broaden, because you'll see patients who are super sick because no one else wants to operate them, and they're transplant patients and they high risk immunocompromised, or you have super young patients who've been putting off surgery because they have pain and they don't want big open surgery. So your practice will shift significantly once you're branded as an endoscopic spine surgeon. And something we didn't talk about in this hour, and I'll say quickly, is it's the patient side, right? It's like the cost and everything, but there's also like patient education. How do they come in? And Dr. Planter said it, how do they come in and ask for it? Hey, do you offer endoscopic spine surgery? And that's a big challenge because, if they walk down to a spine specialist or a spine surgeon or someone who's super specialized, they're going to think they're getting the most advanced spine surgery available and they've been given all the options. But we all know that that's not always the case. So I think we have to figure out a way to solve the problem of empowering patients to ask for endoscopy. Hey, can this thing be done endoscopically? And get 2 or 3 second or more opinions, because people are being told it's contraindicated, it's not possible, oh, that's fake, all this stuff. And these are from other surgeons. So I think we need to empower them to ask more questions and seek out more opinions.
Saqib, some points for everyone to take home.
My point's a little more conceptual in terms of, I was reading this book recently called Think Again by Adam Grant. And there's this one term that he talked about, I think it's so applicable to endoscopic spine surgery or any new innovation in general. It's called cognitive entrenchment. And it's a tendency of experts to become so set in their ways, they struggle to update their thinking or adapt to new information. So I would say that one take-home point is be very wary of cognitive entrenchment based on where you are in your career. Because it goes to my second part, because if you do, if you're not wary of it, then you're not going to be able to really elevate the standard of care that we're currently doing right now with this new technology. And I think it's a movement, whether you do biportal, whether you uniportal, the idea is we're changing the paradigm in how we approach spinal pathology. And I think it's really important that you have to kind of be a little bit disarmed when you approach these new techniques.
Excellent. And Kern, I'd like you to please bring us home.
Bring us home. So endoscopy is here to stay. Everyone should have it as part of their tool, one of their tools in their tool belt. It's not a be all and end all for everything. Very few people ever have that type of practice, but it is something that can make you better. And my last point, or 2 points I have. The second point is I would challenge industry to make it more accessible. The cost is artificial, it's entrenched. It's superficial. You can see it as it applies to the world all over. It's not this just inflationary in the United States. And I think they will lose market share to those who look for alternatives. And the last point that I want to make is I want to thank Chris Young's father, who I saw at many meetings struggle, who thought, people, he was a pariah, a lunatic, a heretic from the first ISAS, which was Spine Arthroplasty Society. I think I'm older than everyone but Chris on this panel. Like that was 19 or 20 years ago. And I watched him get laughed off the stage. And I probably heckled him also at that time. And I want to say thank you to him for standing firm to his beliefs. And it's a much different day and age in spine surgery because of him.
It's excellent. I want to thank the whole panel. This has been.
Ira, can I?
Oh yes. Oh yeah, Jovan. Sorry. Yeah. Hey, how are
I'm
you?
sorry. So I came here for education. I loved the talks from all the spine surgeons. I would just like to put a plug in for Anna, because we've never had a spine course at the Arthroscopy Association of North America. I think this is a wonderful opportunity to bring all the world's experts in spine endoscopy and bring them to the place where really knee, shoulder, and hip arthroscopy was born. And they are now the new leaders in the spine world. And it'd be wonderful to host you guys. It's not paid, it's not industry sponsored. All you get is a hotel room at the Hampton Inn and Suites in Rosemont. And it'd be awesome.
I told this to Bush Joseph. He was the president of ANA, and I told this to Bernie Bach, and I told it to Tony Romeo, and
I
said,
told Shane too.
Yeah, great idea. And Shane actually helped me from hip arthroscopy to to biportal. But I think it's a great thing. I'm here. I'm in Chicago. I'm local, and the Hampton Inn. Well, that sounds luxurious as hell. So
Yeah.
Super nice. You get a double bed. You get 2 bottles of water.
Double bed, man. Who could say
fancy,
no?
man.
Yeah.
But I think it would be really cool to have you guys at the OLC in Rosemont. And I'd love to see you guys there for a course. Ira, Kevin, reach out. I'll reach out to the ANA leadership. And I think it'd be the most amazing course. And I can guarantee you it'll be sold out.
That's a great idea. That really is.
Jovan, do you know Adam Yankee?
Heck yeah. He grew up 2 blocks down from me.
Can I tell you, Adam Yankee, I was taking him through a spine scope just 2 days ago. He was decompressing for me, and it was like seamless. My concern with the practice scope will be the sports guys entering into the spine world and taking all the cases.
I was going to bring that up. I didn't want to interrupt you guys, but I was like, I logged on because I wanted the education. I was like, listen, he's doing biportal. Well, I'm doing endoscopic hamstring and glute repairs.
Yes,
I can probably elevate this to the next level.
Yes, you can. And Shane's been talking to me about that. Absolutely.
Yeah. So you guys are on a great path. I'm excited to see the innovation that comes out of you guys. And like I said, it would probably be a legendary course for ANA and something that's going to bring your world up to the next level, just like Philippon, Bird, and all the old guys, not old guys, all the godfathers did for my field.
That is great news. If Joey could do anything to facilitate that, fine.
Yeah, Ira, we'll have Joey be a part of it.
Yeah, it would be great. We have a new feature at Joey called At the Conference, where we send people to conferences and report on what they're doing. This has been great. Joe, thank you so much for that offer. I want to thank the panelists. This is really one of the most phenomenal open mics we've had. Very open mic. and I can't thank all of you enough. So with that, I'll say good night. And anyone want to contact us or do any follow-up, we could have another endoscopic one early next year, or report on Anna and that activity. So I want to thank everybody and good night.